Let me describe something to you, and I want you to tell me, honestly, whether this sounds familiar. The alarm goes off. Or maybe you didn't even need the alarm because you've been half awake for the last 2 hours anyway. You open your eyes and the first thing you feel is tired. Not the pleasant grogginess of waking from a truly deep sleep. Just tired. Heavy. Like sleep didn't really happen at all, even though you were in bed for 7, 8, maybe even 9 hours. You get up. You make your coffee. Maybe you take your medications, and you spend the first hour or two of your morning just trying to feel like a person. By mid-afternoon, the fatigue hits again, that heavy, foggy wall, and you either push through it or you give into a nap, which then makes it harder to sleep that night, and the cycle repeats. If that description sounds like your life, I want to say something to you very directly. This is not normal aging. This is not just what happens when you get older. And it is absolutely not something you simply have to accept. I'm Dr. Robert Miller, and welcome back to Longevity and Vitality in the Golden Years. Today we are tackling one of the most common and most undertreated problems I see in my practice with older adults, disrupted, non-restorative sleep and the persistent fatigue that comes with it. I see this pattern constantly. Patients who have tried melatonin, tried sleep hygiene tips, tried everything their primary care doctor suggested, and nothing has worked, or it worked for a little while and then stopped. And over time, they've come to a resignation. This is just how it is now. I refuse to accept that resignation, and after today's video, I hope you will too. Because here is the truth. Sleep in the aging body is genuinely more complex than sleep in the younger body. The reasons you're waking up exhausted are real and specific and biological, and they are largely addressable. But addressing them requires understanding what's actually happening, not just reaching for a generic fix. That's what today is about. We're going to go deep into the physiology of sleep after 60, uncover the most common hidden causes of poor sleep in older adults that are routinely missed, and then I'm going to walk you through the 3-step protocol I use with my patients. A protocol that, when followed consistently, has produced some of the most dramatic quality of life improvements I've seen in 30 years of practice. This is a long video because this topic deserves a thorough treatment. Get comfortable. Get your coffee, or better yet, your green tea, and we'll talk about why in a moment. And let's get into it. Before we go any further, I want to ask you something right now. In the comments below this video, tell me just this. On a scale of 1 to 10, how would you rate the quality of your sleep? 1 means you barely sleep at all and wake up feeling terrible. 10 means you sleep deeply, wake up refreshed, and have energy all day. Just a number. 1 through 10. Post it right now while it's on your mind. I read every single comment, and I want to know where you're starting from today, because your answer is going to change by the time you finish implementing what I share with you today. Go ahead, post your number, then keep watching. To understand why you're waking up exhausted, you first need to understand what healthy sleep actually looks like, and how it changes with age. Because most people have a fundamentally incomplete picture of what sleep is, and that incomplete picture leads to incomplete solutions. Sleep is not one thing. It is a complex architecture of distinct stages that cycle throughout the night, each serving critical and different biological functions. Let me walk you through the sleep cycle. A complete sleep cycle lasts approximately 90 minutes and repeats 4 to 6 times per night. Each cycle contains different proportions of the sleep stages. In a healthy sleep cycle, you move through Stage 1, light sleep, the transition between wakefulness and sleep, brief, easily disrupted. This is when you might experience those sudden muscle jerks called hypnic jerks. If you're woken up in Stage 1, you might not even feel like you were asleep. Stage 2, consolidated light sleep. Your body temperature drops, heart rate slows, brain waves slow down with occasional bursts called sleep spindles. You spend more total time in Stage 2 than any other stage, approximately 50% of your total sleep time. This stage is important for motor memory and learning. Stage 3, deep sleep, slow wave sleep. This is the gold standard. This is the most physically restorative stage of sleep. This is when growth hormone is released, the primary hormone responsible for cellular repair, muscle maintenance, bone density, and immune function throughout the body. This is when your body does the vast majority of its physical repair work. This is also when the glymphatic system, the brain's waste clearance system, is most active, flushing out beta-amyloid and tau proteins associated with Alzheimer's disease. This stage is characterized by very slow, high-amplitude delta brainwaves. It is the hardest stage to wake someone from, and it is the stage that is most dramatically reduced with age. Stage 4, REM sleep, rapid eye movement. This is where most vivid dreaming occurs. REM sleep is critical for emotional processing, memory consolidation, creativity, and psychological resilience. During REM sleep, the brain is highly active, nearly as active as when you're awake, but the body is essentially paralyzed, which prevents you from acting out your dreams. REM sleep is essential for learning and for the consolidation of declarative memory, the kind of memory involved in remembering facts, events, and experiences. Now, here is where aging enters the picture, and this is crucial to understand. Beginning in your 40s, and accelerating after 60, the architecture of your sleep changes in very specific, documented ways. First and most significantly, deep sleep, stage 3, slow wave sleep, decreases dramatically. A healthy 25-year-old might spend 20 to 25% of their sleep time in deep sleep. By the time you're 65, that number may have dropped to 5 to 10%, or in some people, nearly zero. This is not a small change. This is a fundamental shift in the restorative capacity of your sleep. This is why you can sleep 8 hours and wake up feeling like you barely slept. Because while you may have accumulated 8 hours of total sleep time, you may have spent very little of that time in the deep restorative stage where the real work happens. Second, sleep fragmentation increases. Older adults wake up more frequently throughout the night. The threshold for awakening lowers, meaning smaller disturbances, a sound, a movement, a temperature shift, a full bladder, pull you out of sleep that younger people would sleep right through. Each awakening, even if you're not fully conscious of it, interrupts the sleep cycle and reduces the proportion of time spent in deeper stages. Third, circadian rhythm shifts. The circadian rhythm, your internal 24-hour biological clock, tends to advance with age. This is called a circadian phase advance. In practical terms, it means many older adults feel sleepy earlier in the evening and naturally wake earlier in the morning. The problem arises when social schedules, lifestyle habits, or artificial light exposure push sleep later than the body's natural clock, creating a chronic misalignment between the internal clock and actual sleep timing that undermines sleep quality profoundly. Fourth, sleep efficiency declines. Sleep efficiency is the ratio of time actually asleep to time spent in bed. A young adult might have a sleep efficiency of 90 to 95%. Many older adults have sleep efficiencies of 70% or less, meaning they spend 30% or more of their time in bed awake, lying there frustrated, unable to fall back asleep. Fifth, changes in sleep-regulating neurochemistry. The production of melatonin, the hormone that signals nighttime to your body and initiates the sleep cascade, decreases substantially with age. The suprachiasmatic nucleus, the brain's master circadian clock in the hypothalamus, becomes less responsive. Adenosine, the chemical that builds up as a sleep pressure signal throughout the day, accumulates and clears less efficiently. And growth hormone secretion, which is tied to deep sleep, declines in a self-reinforcing cycle. Less deep sleep means less growth hormone, and reduced growth hormone means less capacity for the kind of cellular repair that supports deep sleep. This is the genuine biological landscape of sleep in the aging body. And understanding it reveals immediately why generic advice, just go to bed earlier, or try some melatonin, is woefully inadequate. Now let's talk about the additional layer, the hidden medical conditions that are silently destroying sleep in older adults and are routinely missed or undertreated. In my clinical experience, the vast majority of older adults who come to me with sleep complaints have at least one, and often two or three, underlying conditions that are directly contributing to their poor sleep. These are not obscure conditions. They are common. And yet they are frequently overlooked in standard primary care because a 5-minute conversation about sleep typically ends with a prescription for a sleeping pill rather than an investigation into the root cause. Let me walk you through the most important ones. Sleep apnea. This is the single most commonly missed sleep disorder in older adults, and its prevalence increases dramatically with age. Sleep apnea affects an estimated 30 to 40% of adults over 60, and a significant portion of those people are entirely undiagnosed. Sleep apnea occurs when the airway partially or completely collapses during sleep, causing breathing to stop repeatedly throughout the night, sometimes dozens or hundreds of times. Each apnea event triggers a brief arousal from sleep as the brain detects the oxygen drop and forces the airway back open. These arousals are often too brief to reach full consciousness, but they are absolutely sufficient to fragment sleep architecture and prevent sustained deep sleep. The consequences of untreated sleep apnea extend far beyond feeling tired. Sleep apnea dramatically increases the risk of hypertension, atrial fibrillation, heart attack, stroke, type 2 diabetes, cognitive decline, and dementia. It accelerates biological aging, and it creates a metabolic cascade through repeated oxygen desaturation and cortisol spikes that worsens virtually every other health condition. Here is what concerns me clinically. Many older adults with sleep apnea do not present with the stereotypical picture of a loud, gasping snorer. In older adults, and particularly in women, sleep apnea can present as simply waking up unrefreshed, having frequent nighttime urination, because the pressure changes in the airway during apnea events trigger the release of a natriuretic peptide that signals the kidneys to produce more urine, experiencing morning headaches, having dry mouth upon waking, or having unexplained fatigue and brain fog during the day. If you have never been tested for sleep apnea and you wake up feeling unrefreshed, I strongly encourage you to talk to your doctor about a sleep study. Modern home sleep testing has made this much more accessible. You can often do the test in your own bed without going to a sleep lab. Restless leg syndrome and periodic limb movement. Disorder, restless legs syndrome, RLS. The irresistible urge to move the legs, especially in the evening and at night, accompanied by uncomfortable sensations, affects approximately 15 to 20% of adults over 65. It is significantly more common than most people realize. It disrupts sleep onset and sleep continuity profoundly, and many patients have had it for so long they've simply normalized it without realizing it is a treatable medical condition. Periodic limb movement disorder, PLMD, is related. It involves repetitive leg movements during sleep that the person is often unaware of, but which fragment sleep repeatedly throughout the night. A bed partner may notice it before the patient does. Both conditions have known physiological drivers, including iron deficiency. Ferritin levels below 75 ng/ml are strongly associated with RLS severity. This is much higher than the standard normal cutoff most labs use. Magnesium deficiency, dopamine dysregulation, and certain medications including some antihistamines, antidepressants, and anti-nausea drugs. Pain, chronic pain, from arthritis, degenerative disc disease, neuropathy, or any other source, is one of the most common and most obvious sleep disruptors in older adults, and yet it is often not adequately addressed. Pain activates the nervous system and prevents the descent into deeper sleep stages. Even low-grade background pain that doesn't fully wake you up can prevent you from spending adequate time in stage 3 deep sleep. If pain is contributing to your sleep problems, addressing the underlying source of pain through anti-inflammatory nutrition, appropriate physical therapy, targeted supplementation, or medical management is a necessary part of the sleep solution. Nocturia. Nocturia, waking up one or more times per night to urinate, is one of the most common complaints in adults over 60, affecting over 50% of older adults. It is the single most commonly reported reason for nighttime awakening.
And while it is often dismissed as simply a natural consequence of aging, it frequently has addressable underlying causes. Sleep apnea, as mentioned, heart failure causing fluid redistribution when lying down, poorly controlled diabetes causing osmotic diuresis, overactive bladder, benign prostatic hyperplasia in men, excessive evening fluid intake, certain medications, and others. Each awakening to use the bathroom interrupts sleep cycles and makes it harder to return to deep sleep.
This seems obvious, but the cumulative impact on sleep quality and the downstream impact on health is profound and often underappreciated. Cortisol dysregulation. Your cortisol, your primary stress hormone, follows a natural daily rhythm. It should be at its lowest point in the late evening, allowing sleep onset, and rise sharply in the early morning, the cortisol awakening response that helps you wake feeling alert. In people with chronic stress, HPA axis dysregulation, or metabolic dysfunction, this cortisol rhythm can become distorted. Evening cortisol may be too high, preventing sleep onset or causing early morning awakening around 3 or 4 a.m. This is an extremely common pattern I see clinically. Patients who wake between 3 and 5 a.m., heart slightly racing, mind immediately active, unable to return to sleep. This is a hallmark of elevated nocturnal cortisol or blood sugar dysregulation triggering a cortisol response. Thyroid dysfunction. Both hypothyroidism, underactive thyroid, and hyperthyroidism, overactive thyroid, can profoundly disrupt sleep. Hyperthyroidism causing fatigue and excessive sleepiness despite apparent adequate sleep. Hyperthyroidism causing insomnia, anxiety, and racing heart at night. Thyroid dysfunction is common in older adults, particularly in women over 60, and a TSH test should be part of any workup for unexplained fatigue and sleep disruption. Medications. This is a critically important category. Many medications commonly prescribed to older adults are significant sleep disruptors, and this is not always adequately communicated by prescribing physicians. The list includes beta blockers, which suppress nocturnal melatonin production, diuretics, which cause nocturia, particularly if taken in the evening, certain antidepressants, corticosteroids, stimulant-based medications, some blood pressure medications, and, ironically, certain sleeping pills themselves, which may help with sleep onset, but reduce time spent in deep sleep and REM sleep, leaving patients feeling unrefreshed. If you are on multiple medications and struggling with sleep, I strongly encourage you to have a careful medication review with your physician, specifically asking, could any of my medications be affecting my sleep quality? Now that you understand what's happening, both the fundamental biology of aging sleep and the most common hidden disruptors, let me give you the practical solution. This is the 3-step protocol I use with my patients, and it is built on 3 principles: fix the foundation, regulate the clock, and deepen the sleep. These 3 steps work synergistically. Each one is meaningful on its own, but the combination is where the transformative results come from. Step 1. Fix the foundation. The most sophisticated sleep optimization techniques in the world will not overcome an undiagnosed case of sleep apnea, undertreated pain, or medications that are actively suppressing deep sleep. This is why step 1 is not about supplements or sleep hygiene. It's about asking the right questions and getting the right information. Here is the foundation checklist I go through with every patient who presents with sleep complaints. 1. Have you been tested for sleep apnea? If not, and if you wake up feeling unrefreshed, have nocturia, experience morning headaches or dry mouth, or have been told you snore, a home sleep study is a reasonable and relatively simple next step. CPAP therapy, when sleep apnea is present, often produces dramatic improvements in energy, mood, cognitive function, and long-term cardiovascular health. It is one of the highest impact interventions available for older adults with this condition. 2. What are your iron and ferritin levels? Not just hemoglobin, specifically ferritin. A ferritin level below 75 angstrom can drive or worsen restless legs syndrome and general sleep quality. Many people have ferritin levels that fall within the lab's normal range, but are actually suboptimal for sleep health. Ask your doctor to check your ferritin specifically. 3. What does your thyroid panel look like? TSH, free T3, and free T4 should all be checked. Don't accept your TSH is normal as the full story if you have ongoing unexplained fatigue. Optimal TSH for most people is between 1.0 and 2.0, and normal lab range goes up to 4.5 or even higher depending on the lab. 4. Review your medications. Go through every single medication and supplement you take, prescription and over-the-counter, and specifically ask your pharmacist or physician, does any of this affect sleep quality or melatonin production? 5. Address pain. If chronic pain is disrupting your sleep, it needs to be addressed as a primary component of your sleep plan, not as a separate issue. Anti-inflammatory dietary changes, targeted supplements like turmeric with piperine, omega-3 fatty acids, and appropriate medical management of underlying conditions can all meaningfully reduce nocturnal pain burden. 6. Address nocturia root causes. If you're waking 2 or more times per night to urinate, talk to your doctor about the underlying cause. Simple initial steps include stop drinking fluids 2 to 3 hours before bed, avoid alcohol and caffeine in the evening, elevate your legs for an hour before bedtime if you notice leg swelling during the day, which can indicate fluid redistribution that will cause nocturia once you lie down, and ask about sleep apnea evaluation, since this is a very common but underappreciated driver of nocturia in older adults. Getting step 1 right is the difference between someone who does everything else perfectly and still wakes up exhausted versus someone who makes targeted foundational fixes and experiences a rapid, dramatic improvement. Do not skip this step. Step 2. Regulate the clock. The circadian rhythm is the master regulator of sleep. When it is strong, consistent, and properly aligned, falling asleep and staying asleep become dramatically easier, because your biology is working with you instead of against you. When it is weak, inconsistent, or misaligned, as it often is in older adults for reasons I'll explain, sleep is a constant struggle, regardless of how good your sleep hygiene is. Here is the Step 2 protocol for regulating and strengthening the circadian rhythm. Morning light exposure. This is the most important thing in Step 2. Within 30 minutes of waking, get outside and expose your eyes to natural daylight for at least 10 to 15 minutes. If weather prevents this, sit near a bright window or use a therapeutic light box, 10,000 lux, for 20 to 30 minutes. Do not wear sunglasses during this exposure. You do not need to be looking directly at the sun. Simply being outside in daylight with your eyes open is sufficient. Here is why this is so profoundly important. The suprachiasmatic nucleus, your master circadian clock, receives direct input from specialized photoreceptors in your eyes, called intrinsically photosensitive retinal ganglion cells. When these cells receive bright light in the morning, they send a morning signal to the SCN that sets your biological clock for the day. This morning, light signal does several things simultaneously. It triggers the cortisol awakening response, the healthy morning cortisol spike that gives you energy and alertness. It suppresses any lingering melatonin, and most importantly, it sets a biological timer so that your body will naturally begin producing melatonin again approximately 14 to 16 hours later, right when you want to be falling asleep. Without consistent morning light exposure, this timer becomes irregular. Your circadian clock drifts. Melatonin onset time becomes unpredictable. Sleep quality suffers. This single habit, 10 to 15 minutes of morning sunlight within 30 minutes of waking, is one of the highest leverage, zero-cost interventions for sleep quality I know of, and it takes almost no effort. Consistent sleep and wake times, 7 days a week. This is the one that most people resist the most, and it is non-negotiable. Your wake time, in particular, should be the same every single day, including weekends, not within an hour, the same time. Here is why. Your wake time is the primary anchor for your circadian rhythm. When you wake at the same time every day, your body can precisely calibrate when cortisol should rise, when melatonin should fall, when adenosine should clear, and when deep sleep should occur. When you sleep in on weekends, even by 90 minutes, you create a phenomenon called social jet lag that desynchronizes your circadian rhythm and undermines the sleep quality of the following several days. I understand that for people who are retired or semi-retired, the temptation to let the schedule slide is strong. But the science on circadian consistency is unambiguous. Pick a wake time that works for your life. Commit to it every day. Avoid long naps in the afternoon. Strategic napping can be beneficial. A nap of 20 to 30 minutes before 2 p.m. can restore alertness and support afternoon cognitive function without meaningfully affecting nighttime sleep. But long naps, over 45 minutes, or naps taken after 3 p.m., dramatically reduce your sleep pressure, adenosine accumulation for the evening, making it much harder to fall asleep or stay in deep sleep at night. Many of the patients I see with insomnia are caught in a self-reinforcing trap. They sleep badly at night, they take a long afternoon nap out of exhaustion, and the nap makes them sleep even worse the following night. If you are struggling with nighttime sleep, limit daytime naps to 20 minutes maximum and only before 2 p.m. Evening light. Management. Just as morning light sets the clock, evening blue light disrupts it. Blue light, the type emitted by LED screens, smartphones, tablets, computers, and most modern artificial lighting, suppresses melatonin production by signaling to the SCN that it is still daytime. Exposure to bright blue light in the 2 to 3 hours before bed can delay melatonin onset by 1 to 3 hours, pushing sleep later and reducing deep sleep time. For my patients, I recommend 3 practical evening light strategies. First, dim your indoor lighting significantly from about 8 p.m. onwards. Use lamps with warm-toned bulbs rather than bright overhead lighting. Second, use blue light blocking glasses in the evening if you watch television or use screens. These are inexpensive, widely available, and make a measurable difference in melatonin timing for many people. Third, avoid screens in bed entirely. The bed should be associated exclusively with sleep and intimacy, not with phones, tablets, or television. This is a behavioral conditioning principle that has strong evidence supporting it. Temperature. Your body needs to drop its core temperature by approximately 1 to 1.5 degrees Celsius in order to initiate and maintain deep sleep. This is why a cool bedroom environment is so important. I recommend a bedroom temperature between 65 and 68 degrees Fahrenheit, 18 to 20 degrees Celsius, for optimal sleep. If you struggle with temperature regulation at night, which is common in older adults, consider cooling mattress toppers, moisture-wicking bedding, or simply adjusting your thermostat. A warm bath or shower taken 90 minutes before bed can paradoxically help. The warm water raises your skin temperature, which then triggers compensatory vasodilation and heat dissipation, lowering your core temperature as you get out of the bath, mimicking and accelerating the natural cooling process that initiates deep sleep. Caffeine cutoff. Caffeine has a half-life of approximately 5 to 7 hours in the average adult, but in older adults, the clearance rate slows. A cup of coffee consumed at 2 p.m. may still have 50% of its caffeine active in your system at 9 p.m. I recommend a strict caffeine cutoff of noon, no caffeine of any kind after 12 p.m. for anyone struggling with sleep quality. This includes coffee, tea, except herbal, many sodas, and some medications that contain caffeine. This is one of those recommendations that patients frequently resist, and then, when they finally try it, tell me it made an enormous difference. I want to take a moment right here because we're about to get into step 3, which is where we talk about the specific supplements and advanced techniques that deepen sleep quality at the biological level, and I think this section is going to be especially valuable for you. But before we go there, I want to ask you to do something. If you have a spouse, a partner, a sibling, or a close friend who you know struggles with sleep, someone who is always tired, who jokes about never sleeping well, who has just accepted exhaustion as their reality, I want you to send them this video right now. Not later. Right now. Pause this, pull up their contact, and send it. Because everything we're discussing today is information that could genuinely change their health trajectory. Sleep is not a luxury. It is a biological necessity that affects every single system in the body. The person in your life who needs this information deserves to have it. Send it now. Then come back and we'll finish step 3 together. Step 3. Deepen the sleep steps. 1 and 2 create the conditions for good sleep. Step 3 provides targeted biochemical support to deepen the sleep that occurs within those conditions, specifically to increase time spent in stage 3 deep sleep, which, as we discussed, is the most critical and most depleted stage in the aging body. Let me walk you through the specific interventions that have the most meaningful evidence for improving sleep depth and quality in older adults. Magnesium, the foundation of sleep. Supplementation. Magnesium is the single most important supplement for sleep in older adults, in my clinical opinion, and I say that with confidence based on both the research and what I see with my patients. Here's why. Magnesium is required for the activation of GABA receptors in the brain. GABA is the primary inhibitory neurotransmitter, essentially the calm down and switch off signal that allows sleep to occur. Without adequate magnesium, GABA signaling is impaired, and the nervous system struggles to downregulate from the alert, active state of waking into the quiet, slow state required for deep sleep. Magnesium also regulates the release of melatonin and is required for the conversion of tryptophan to serotonin to melatonin. The entire sleep initiation cascade depends on adequate magnesium at multiple steps. It also reduces cortisol levels and helps regulate the HPA-axis stress response that, when dysregulated, causes nocturnal cortisol spikes and early morning awakening. And, critically, most Americans over 60 are deficient in magnesium. Dietary intake is inadequate for most people, and absorption decreases with age. For sleep specifically, I recommend magnesium glycinate, the glycine chelate form, or magnesium threonate, which crosses the blood-brain barrier particularly well. Dosing: 300 to 400 mg taken 60 to 90 minutes before bed. Start with a lower dose and titrate up gradually. Loose stools indicate you've exceeded your current tolerance, in which case reduce the dose or switch to the glycinate form, which is gentler on the digestive system. In my patients, magnesium supplementation, when they have been deficient, which is most of them, often produces noticeable improvements in sleep depth within 1 to 2 weeks. Low-dose melatonin. Less is more. Melatonin is the most widely used sleep supplement in the United States, and it is widely used incorrectly. The doses sold in most American pharmacies, 5, 10, even 20 milligrams, are pharmacological doses that are far in excess of what the body naturally produces and what research suggests is effective for sleep quality in older adults. The evidence for melatonin in seniors actually supports very low doses, 0.5 to 1, 5 milligrams, taken 60 to 90 minutes before the desired sleep time. At this dose, melatonin acts more like a physiological signal, telling the body that it's nighttime, rather than a sedative. High doses, paradoxically, can disrupt sleep architecture, cause vivid dreams or nightmares, and create a grogginess the following morning. If you've tried melatonin and found it didn't work, or made you groggy, I'd encourage you to try a low-dose formulation, Bari 0, 5 to 1 mg, taken 90 minutes before bed, rather than the high doses that are unfortunately standard on pharmacy shelves. I want to be clear. Melatonin is most effective for circadian rhythm disorders, difficulty falling asleep or adjusting to a new sleep schedule, rather than for maintaining deep sleep throughout the night. It is a tool with a specific application, not a universal sleep solution. L-theanine. L-theanine is an amino acid found naturally in green tea, which is one of the reasons I recommend green tea as an evening beverage, in decaffeinated form, of course. L-theanine promotes a state of calm, relaxed alertness without sedation by increasing alpha brainwave activity, the same brainwave pattern associated with meditation and the relaxed but focused state just before sleep onset. It also increases GABA, serotonin, and dopamine levels in the brain. For sleep, L-theanine is particularly valuable because it reduces the anxious, racing mind quality that many people experience at bedtime, the inability to switch off thoughts. Unlike benzodiazepines or other sedatives, it does this without impairing cognition, causing dependence, or suppressing deep sleep stages. I recommend 100 to 200 milligrams of L-theanine taken 60 minutes before bed. It pairs very well with low-dose melatonin and magnesium glycinate in an evening sleep stack. Many of my patients find this combination, magnesium glycinate, low-dose melatonin, and L-theanine, to be transformative for sleep onset and sleep quality. Glycine. Glycine is a conditionally essential amino acid with very interesting sleep data behind it. Several human studies have found that taking 3 grams of glycine before bed shortens sleep onset time, increases sleep efficiency, reduces daytime fatigue, and improves subjective sleep quality, without causing any of the grogginess associated with sedative medications. The proposed mechanisms include glycine's ability to lower core body temperature. As we discussed, core cooling is essential for deep sleep, and its role as an inhibitory neurotransmitter in the spinal cord and brainstem that promotes muscle relaxation during sleep. 3 grams of glycine powder taken before bed is inexpensive, safe, has a pleasant sweet taste, and the evidence supporting its sleep benefits is genuinely compelling. I recommend it regularly to patients who are looking for additional support beyond the basics. Addressing cortisol and the 3 a.m. awakening. For patients who wake consistently between 2 and 5 a.m. and cannot return to sleep, I look specifically at 2 things: cortisol dysregulation and blood sugar stability. For cortisol, adaptogenic herbs, particularly ashwagandha, Withania somnifera, which has multiple high-quality randomized controlled trials supporting its ability to reduce cortisol, reduce stress, and improve sleep quality, can be helpful for people with HPA axis dysregulation. A dose of 300 to 600 mg of a standardized ashwagandha extract taken in the evening has shown meaningful improvements in sleep quality in several human trials. For blood sugar, some people wake at 3 a.m. because of a nocturnal blood sugar drop, particularly if they are pre-diabetic, insulin-resistant, or if they have had a high glycemic dinner that caused an evening blood sugar spike followed by a reactive drop in the early morning hours. A small, protein and fat-based snack before bed, a tablespoon of nut butter, a small handful of almonds, a hard-boiled egg, can stabilize blood sugar through the night and prevent these early morning awakenings. Counterintuitively, going to bed on an empty stomach after a blood sugar spike is often worse than having a small, low-glycemic snack. Avoid sedative sleep medications when possible. I want to address this directly because many of my older patients are on prescription sedatives or over-the-counter sleep aids and don't realize what these medications are doing to their sleep architecture. Benzodiazepines, Valium, Xanax, Ativan, Restoril, etc., and Z-drugs, Ambien, Lunesta, Sonata, do help people fall asleep and stay asleep in a quantitative sense, but they do so by suppressing the very slow-wave deep sleep and REM sleep that makes sleep restorative. You may spend 8 hours sedated, but you wake up feeling as though you barely slept, because, in a meaningful neurological sense, you didn't. The brain was suppressed, not genuinely sleeping. These medications also carry significant risks in older adults: increased fall risk, cognitive impairment, paradoxical agitation, and rebound insomnia when discontinued. The American Geriatric Society specifically lists benzodiazepines and Z-drugs on their Beers criteria, a list of medications that are potentially inappropriate for older adults due to their risk-benefit profile. I am not saying never, under any circumstances. There are situations where short-term use is medically appropriate. But if you are using these medications nightly or near nightly for sleep, I strongly encourage you to have a conversation with your physician about whether you can work toward discontinuation through the behavioral and supplemental approaches we've discussed today, and potentially with the support of a sleep specialist or a supervised tapering protocol. The goal is not just to be asleep. The goal is to be genuinely, deeply, restoratively asleep. The kind of sleep that repairs your body, clears your brain, and has you waking up feeling ready for your day. I want to take a step back now and make sure you understand the full stakes here, because I've found that when people understand not just how to improve their sleep, but why it matters so profoundly for their long-term health. Their motivation to implement these changes becomes much more powerful. The research on sleep and longevity is, frankly, alarming. And I say alarming not to frighten you, but to help you understand that getting serious about your sleep is one of the highest leverage health investments you can make. Sleep and Alzheimer's disease. I've mentioned the glymphatic system and beta amyloid clearance several times today. Let me put some numbers on it. Studies using PET imaging have shown that after just one night of sleep deprivation, beta amyloid accumulation in the brain increases by approximately 5%, measurably, acutely, after just one night. People who report chronic short sleep duration have significantly higher rates of amyloid plaque accumulation and a meaningfully increased risk of developing Alzheimer's disease. One large study followed participants for 25 years and found that consistently sleeping 6 hours or less per night in midlife was associated with a 30% increased risk of dementia. Not a small effect, a very large effect. Sleep and cardiovascular disease. Sleep duration and quality are independently associated with risk of hypertension, heart attack, atrial fibrillation, and stroke. People who sleep less than 6 hours per night have a significantly higher risk of heart attack than those who sleep 7 to 8 hours. The mechanisms involve inflammatory activation, cortisol dysregulation, sympathetic nervous system overdrive, and endothelial dysfunction. Sleep and immune function. The immune system performs critical maintenance and memory consolidation during sleep, particularly during deep sleep. Vaccination studies have shown that people who sleep less than 6 hours per night in the days following vaccination produce significantly fewer antibodies than those who sleep 7 or more hours. This means that if you are chronically sleep deprived, your immune system is not just less able to fight off infections in the short term, it's less capable of mounting the kind of adaptive immune responses that protect against cancer and chronic disease in the long term. Sleep and metabolic health. Sleep deprivation increases ghrelin, the hunger hormone, and decreases leptin, the satiety hormone, creating a hormonal environment that drives overeating and weight gain. It increases cortisol, which promotes visceral fat accumulation. It impairs insulin sensitivity, increasing diabetes risk. Even short-term sleep restriction of 4 to 5 days produces measurable increases in fasting glucose and insulin resistance in healthy adults. Sleep and muscle maintenance. As we discussed in previous videos, sarcopenia, the loss of muscle mass with aging, is a critical health concern for older adults. Deep sleep is when growth hormone is primarily secreted, and growth hormone is one of the primary anabolic signals driving muscle protein synthesis and repair. Inadequate deep sleep directly undermines your ability to maintain muscle mass, even if your protein intake and exercise habits are excellent. The bottom line is this: if you are skimping on sleep, you are accelerating aging across every biological system simultaneously. And if poor sleep is being caused by one of the treatable, addressable conditions we've discussed today, you are carrying a burden that you do not need to carry. Let me tell you about a patient I'll call Richard. Richard was 71 years old, a retired attorney, meticulous and disciplined in almost everything he did. He ate reasonably well. He walked every day. He had good relationships and an engaged mind. By all visible measures, he was doing many things right. But he was exhausted. He had been exhausted for so long that he had simply accepted it as his new normal. He told me he slept about 7 hours most nights, sometimes more, but never felt rested. He had afternoon energy crashes that he managed with an extra cup of coffee. He had increasing difficulty concentrating on complex legal materials he still read to stay sharp. His wife told me privately that he had become irritable in a way that wasn't characteristic of him. Richard had never been tested for sleep apnea. He didn't snore loudly. His wife said he made occasional sounds, but nothing dramatic. His primary care doctor had offered him a prescription for a sleep aid, which he had declined. He'd tried melatonin, 10 mg, a common pharmacy dose, and found it made him groggy and didn't help. He had more or less given up. Here is what we found when we actually investigated. First, I ordered a home sleep study, The results showed moderate obstructive sleep apnea, an apnea-hypopnea index of 19 events per hour. Moderate apnea, not severe. Not the kind of dramatic, gasping, witnessed apnea that most people picture. Just quiet, regular, repetitive airway obstructions fragmenting his sleep 19 times every hour all night long. He had been sleeping for years while his brain was being repeatedly pulled out of deep sleep, his oxygen dropping, his heart being stressed. And he had no idea. Second, his ferritin was at 42 ng/ml, technically within the standard normal range, but well below the 75 ng/ml threshold associated with optimal sleep and absence of restless leg symptoms. He acknowledged when I asked directly that he often felt an uncomfortable restlessness in his legs at night that he had never mentioned because he thought it was insignificant. Third, his evening cortisol was elevated, consistent with chronic stress dysregulation. He had been dealing with a difficult family situation for about 2 years that he had minimized in our initial conversation. Fourth, and this surprised him, his evening habits included 2 glasses of wine with dinner, 3 to 4 nights per week, which he had always thought was harmless. We addressed all 4 simultaneously. He started CPAP therapy for the sleep apnea. We supplemented iron under monitoring to bring his ferritin up. I started him on magnesium glycinate and ashwagandha in the evening for the cortisol dysregulation. We had an honest conversation about the alcohol, and he reduced it to 1 glass on occasional evenings only and never within 3 hours of bedtime. Within 6 weeks, Richard came in and sat down and said, "And I will remember this," he said. "I forgot what it felt like to wake up like a person." His concentration had improved markedly. The irritability his wife had noticed was largely gone. His afternoon crashes had disappeared. He no longer needed afternoon coffee. At 3 months, his AHI on repeat testing with CPAP was below 1 event per hour. He told me he had started adding 30 minutes to his daily walk because he had the energy. Richard's sleep wasn't broken because of age. It was broken because of 4 specific, identifiable, addressable problems that no one had investigated. The age piece was real. The deeper biological changes in sleep architecture were real, but they were being enormously compounded by completely addressable factors. That is the pattern I see over and over again. And it is the reason I find sleep medicine in older adults so rewarding, because the interventions actually work, and the improvements they produce ripple outward into every other dimension of health and quality of life. Q. Dr. Miller, I've tried everything for sleep and nothing works. I'm convinced this is just how it is for me at my age. What would you say to me? I would say, you haven't tried everything yet. You may have tried many things, but probably not in the systematic, root cause-focused way we've outlined today. The most common error I see is people trying sleep hygiene tips and supplements without first addressing the foundational issues: undiagnosed sleep apnea, iron deficiency, medications, cortisol dysregulation. You can take the perfect supplement stack and follow perfect sleep hygiene and still sleep terribly if you have undiagnosed sleep apnea. Conversely, I have patients who tried everything for years and found that treating their sleep apnea solved the problem almost completely. I would urge you not to give up, but to go deeper in your investigation before concluding there's no answer. Q. Is it true that older people just need less sleep? Someone told me 7 hours is too much at my age. This is a widespread myth that I want to put to rest firmly. The National Sleep Foundation's current recommendations, based on extensive research, are 7 to 8 hours per night for adults over 65. While it is true that sleep architecture changes with age, specifically the proportion of deep sleep and REM sleep decreases, the total sleep need does not decrease significantly. What does change is sleep efficiency, meaning older adults often need to spend more time in bed to obtain adequate total sleep time because they wake more frequently. The idea that older people need less sleep has been used to normalize a problem that is actually causing widespread health harm. 7 to 8 hours of genuine sleep remains the target. Q. What about sleep trackers like the Oura Ring or Apple Watch? Are they accurate for older adults? Consumer sleep trackers have improved significantly in recent years and are reasonably accurate for tracking total sleep duration and broad sleep stage estimates. They are excellent for tracking trends over time. If your deep sleep consistently increases after implementing these changes, the tracker will reflect that, even if the absolute stage measurements aren't as precise as a clinical polysomnography. For most purposes, they are useful motivational and feedback tools. Where they fall short is in diagnosing clinical conditions like sleep apnea. A proper sleep study is still necessary for that. But as a general health monitoring tool, I think they provide value for engaged, health-conscious older adults. Q. I fall asleep fine but wake up at 3 a.m. and can't go back to sleep. Is that a different problem from regular insomnia? Yes. This is called sleep maintenance insomnia, or early morning awakening, and it has somewhat different drivers than sleep onset insomnia. The most common causes in older adults are elevated nocturnal cortisol, which I discussed earlier, blood sugar dysregulation causing a reactive hypoglycemic response in the early morning hours, sleep apnea, which causes arousals throughout the night but is often most disruptive in the second half of the night when REM sleep predominates and upper airway muscle tone is lowest, and depression. Early morning awakening is one of the classic neurovegetative symptoms of depression in older adults. If this is accompanied by persistent low mood, loss of interest, or changes in appetite, please talk to your physician. The approach is to identify which of these is driving your specific pattern and address it directly. We've covered a tremendous amount of ground today, and I want to make sure that all of this valuable information doesn't just stay in your head as interesting things I heard. I want it to become action. So here's my challenge to you, right now, before this video ends. Pick one thing from today's video that you are going to implement starting tonight. Just one. It could be moving your caffeine cutoff to noon. It could be getting outside for 15 minutes of morning sunlight tomorrow. It could be ordering magnesium glycinate. It could be calling your doctor this week to ask about a sleep study. Just one thing, and then come back to the comments and tell me what you chose. Tell me. I'm going to start with Kama Brow, because that comment makes it real. That comment makes it a commitment. And when you do it, and start feeling the difference, I want you to come back and tell me that too. Your story might be the thing that inspires someone else to make the same change. This community is built on exactly that kind of shared progress. So tell me, what are you starting with tonight? Sleep is not a passive activity. It is not time that simply disappears while you're unconscious. Sleep is arguably the most biologically active period of your entire day. The time when your brain clears its waste, your cells repair themselves, your immune system consolidates its defenses, your memories are organized and consolidated, and your hormonal systems reset for another day. When sleep is impaired, whether by age-related architectural changes, undiagnosed medical conditions, poor sleep habits, or medications, everything downstream suffers. Your cognition, your mood, your cardiovascular health, your immune function, your metabolism, your muscle maintenance, your longevity itself. But the reverse is equally true. When sleep is restored, when you address the foundation, regulate the clock, and deepen the sleep, the benefits are felt rapidly and broadly. I have watched patients who have been exhausted for years rediscover what it feels like to wake up rested. Patients who had attributed their brain fog, their irritability, their lack of energy, their declining memory to just getting older, and found that it wasn't age at all. It was sleep. Richard found it. You can find it too. The 3 steps I've given you today are not complicated. They are not expensive. They do not require a prescription. They require attention, consistency, and the willingness to investigate rather than accept. Your body wants to sleep deeply. It is designed to sleep deeply. It just needs the right conditions and the right support. Give it those things, and watch what happens. I'm Dr. Robert Miller, and this is Longevity and Vitality in the Golden Years. I will see you in the next video. Sleep well tonight. You deserve it.